Presenting a video titled Limbal Lensectomy, a step towards perfect vision in a child. Limbal lensectomy was first described by Kansky et al. For congenital cataract with corneal diameter less than 10 millimeters, where intraocular lens implantation is not possible. We can do a limbal based approach for lens removal. The best time to operate is less than 4 weeks for unilateral congenital cataract and less than 6 weeks for bilateral congenital cataract. In around 50% of cases, the etiology of congenital cataract is not known. The preoperative preparation includes blood investigations, especially torch assay, cardiac evaluation, especially for cases of rubella cataract, which might be associated with congenital heart disease, preoperative evaluation by a pediatrician and anesthetist prior to general anesthesia, and pediatric intubation set and emergency drugs should be kept ready. There is a debate about bilateral surgery, performing surgery bilaterally in the same sitting in order to avoid repeated general anesthesia. Counseling of parents also becomes important, especially sensitizing the parents about the possible visual outcome in cases of congenital cataract surgery. We need to explain the necessity of early surgery, the need for post-operative care, visual rehabilitation, and frequent follow-ups with the pediatric ophthalmologist. Parents need to be told that surgery is not the end but just the beginning of the long treatment, which includes visual rehabilitation and medical treatment. And in spite of the best efforts which are being taken, the child might have guarded visual prognosis depending upon his visual development and the condition of posterior segment. Now presenting a video, an unedited video of a patient undergoing limbal lensectomy. He was a 2-month-old child. After side port entry, we do implant irrigation cannula at 2 o'clock position and then introduce the 23 gauge vitrectomy cutter from 10 o'clock position and start doing the anterior capsulotomy. At this stage, the mode is irrigation cut aspiration with minimal cut rate and minimal aspiration. The aim is to create an anterior capsular opening. The settings which are at this stage are minimal cut rate and aspiration. The cut rate is around 50 to 70 cycles per minute and aspiration is around 50 cc per minute. And the aim is to create a large anterior capsular opening, but we leave behind a rim of the capsule so as to be in a position to put a secondary intraocular lens later on. As there is a calcified cortex here, we increase the cut rate temporarily to around 400 cycles per minute to get rid of the calcified cortex and calcified anterior lens capsule. Once we reach the lens matter, then we change the mode to irrigation, aspiration and cut. Here we don't need cut, but mainly we have to aspirate the cortical fibers. The aspiration is 400 cc per minute with a minimal cut rate. We can do a bit of cutting, especially for the calcified part of the cortex. Ensure that we don't touch the iris at any point of time, because the uveal tissue in children is highly sensitive and can generate a lot of inflammation. Also ensure that we remove the cortex completely. We don't leave behind any of the cortical fibers. Usually the lens matter comes en bloc and there are not much of cortical fibers left behind. Especially for the sub-incisional part of the cortex, you ensure that it is removed completely with minimal chamber fluctuations, and avoid changing the hands or changing the ports, because the moment we come out with the instrument, the chamber collapses. So the basic concept is that once you enter, you have to finish the surgery and then you come out. Now the cortical matter or the lens matter is almost completely removed. Now we go to the next step, that is the posterior capsulotomy. At this stage we again shift the mode to irrigation cut aspiration with minimal cut rate and minimal aspiration, which is the same as what we will do for anterior capsulotomy, that is around 50 cycles per minute of cut rate and minimal aspiration. And now we go to the anterior vitrectomy. We ensure that we do a thorough anterior vitrectomy with a cut rate. Now we increase it to around 800 to 1000 cycles per minute, and do a thorough anterior vitrectomy and ensure that there are no vitreous fibers or vitreous threads in the anterior chamber. We can use the irrigation cannula to ensure that. Once we are done, we keep the irrigation cannula, withdraw the cutter or vitrectomy cutter, and hydrate the ports with minimal chamber fluctuation. In this case, we also performed surgery for the other eye in the same sitting and did a refraction and fundus examination, which was found to be normal. The post-operative medicines include topical steroids, antibiotics, and homatropine eye drops, and also anti-glaucoma agent to reduce the chances of raised intraocular pressure. The postoperative follow-up is on first and third postoperative day, where we check for anterior chamber reaction and anterior chamber integrity. Then a weekly follow-up for 1 month, and at 3 months we check the intraocular pressure under general anesthesia or under sedation. And usually we consider putting a secondary intraocular lens at 18 months to 2 years of age when the corneal diameter is more than 10 millimeters. Visual rehabilitation is an important part. We immediately ask the parents to make the glasses when we do the refraction on table after the surgery, and we overcorrect by around 2.5 to 3 diopters. We procure a flexible frame and then consider a secondary intraocular lens at 18 months to 2 years of age. Thank you.